Hello, everybody. Today I'm going to be focusing this brief overview on Module 4, which is a therapeutic communication topic and section, which is very, very important in nursing, not only mental health nursing, but also important in life. We all understand what communication is, and that's the process of sending a message to someone. I'm sure every one of you has, at some point in time, has played the telephone game where a bunch of people sit in a circle and somebody starts off giving a message, and the message is whispered into ears until it comes back, and then the last person reveals what that message is. And 9 times out of 10, that message sounds nothing like what the original sender wanted it to be. We have to remember that and be very, very clear in how we communicate with our patients. It's very, very vital that we understand a lot of things that are going on. You all know that there's a lot to communication. We have verbal, we have vocal, and we have visual. Verbal is the stuff we say. We can say things in an animated way, hello, students, and we can say things in a flat way, hello, students. That plays a big part in how people listen to us and how they interpret what we're saying. Do we sound interested? Are we engaged in the conversation? Are we excited about something or are we depressed about something? Then that plays a role with our voice and our tone. So that vocal part of it and the way our face is looking is very important. Then we have the visual. And the visual is sometimes almost more important than what we are actually saying and what people are hearing. They're looking at how are we presenting ourselves? Are we staring off into a corner? Are we closed with our arms closed? Is our body language closed? Are we showing our emotions on our sleeve? I'm sure you've all talked to somebody that you felt wasn't listening to them and they were very, very disinterested. They were maybe paying attention to something else. I have an issue with this a lot of times when I'm doing face-to-face lectures. I look up and my students are buried in a computer. I know they're not listening to me. They're not interacting verbally. They're not speaking, and visually they're buried in their computers. So keep that in mind. We are going to, in this course, we're talking about people with mental illness, and they already are coming with some confusion in their brain. Remember, they're cognitively impaired at that time. They may be depressed. They may be seeing things, hearing things. They may have psychosis. So all of those things going on are going to interfere with your communication. The nonverbal behaviors may be all they see. Another area that you need to focus on here is um, the type of messages that we are sending. There are two terms that you must understand. Congruent means that the way our bodies look and the message makes sense. Incongruent is a confusing message. So if we had somebody coming in and saying, I had the best day of my life, there's two ways they could say that. I had the best day of my life. Or if they said, I had the best day of my life. The latter one is incongruent. My actions and my body actions are not showing a congruency. That, in many cases, comes from the mental illness. And so that is a symptom, or that is something that we need to focus in on. There's also different communication styles within the cultures. Hispanic Americans generally use a lot of body language. French and Italian Americans have usually very animated facial expressions and expressive hand gestures. The Asian cultures really do not show a lot of emotion. They consider that to be private. Some cultures do not like direct eye contact and they consider it disrespectful and improper. So in America here, most of us think that eye contact is very, very important. And if we don't see eye contact, people aren't listening. But it could also be a cultural reason that they're not listening to you. Also, touch. We're touching our patients in many cases. When we're in a med-surg environment, a medical environment, we are doing things in people's personal space. They need to know that that's coming and it needs to be explained. So we need to verbally communicate before we touch. In a mental health setting, a lot of times we don't touch our patients. They are already afraid, they're already in fear, and they're not interpreting signals correctly. So we need to be very careful who we're communicating with and how we're doing that. An area that's really, really important is active listening. I'm sure that you all understand what active listening is, but it includes observing the client's verbal and nonverbal behaviors. That means we're looking for all of that. We're going to look for things that are inconsistent and need more clarification, and we're going to ask them to clarify. We're not going to judge. We also need to provide feedback to the client in a shadowing way, meaning we're not going to be judgmental. We're not going to tell them what to do, but we're going to clarify with them what they said. Another tactic or another strategy we can use is silence. Silence is not the absence of communication. Silence, used properly, gives the person or the patient time to collect their thoughts. Silence is really worthwhile as long as it is serving some function and it's not frightening to the client. A lot of times, people who have a lot of symptoms from a mental illness are having trouble finding the words, are having trouble communicating. Giving them that time is really important. Not to make them feel uncomfortable, but a lot of times they will open up and talk to you. Like, some clarifying techniques that you need to know are paraphrasing. What does that mean? If a client said something to me, I could say back to them, in other words, you seem to be saying, and have them explain it again. If I don't understand, restating, you're basically echoing the client's feelings right back to them. And then reflecting. That's an example of that would be the client says, my brother spends all of his money and has the nerve to ask for more. The nurse would say, it appears this causes you to feel angry. Instead of saying, why do you let him take money? That would be offering advice. All right, let's keep moving on here. We also want to explore and we want to examine ideas much more fully. So we would say to the patient, tell me more about that. Would you describe that more fully? There's a lot of examples in your book, and you need to really make sure that you understand some of these because you will get questions on your exam and even on NCLEX that is what's the appropriate response. Another thing that we do is we focus. We concentrate on a single point. This sometimes helps when we're doing medication teaching or giving discharge teaching. We are going to concentrate on a single area of communication and not go off in all different directions. Again, we're dealing with patients who aren't communicating correctly and they're not maybe able to follow you because of their symptoms. We're going to seek clarification. So a really great statement to roll off your tongue is, I'm not sure I follow you. That opens up the area for the patient or the patient to come back and say something again so you can understand. We also want to present reality. We never want to lie to a patient. We never want to tell them that everything's going to be okay. We want to be forthcoming and not give false hope. Let me see what else here. We want to offer ourselves. This is really important. Never go into a patient's room when you have a time limit. You want to be able to offer yourself and spend time with the patients as best you can. Now, that doesn't mean that you're going to stay in a patient's room for a half hour, but we're not going to rush in, do tasks, and rush out. We need to communicate with the patient so that you can do the teaching that you need to do, so that you develop a relationship with them, so that you develop trust. Trust is very, very important. We also want to make many observations. And when we communicate, we want to give that back to the patient and say something like, you appear tense. You appear afraid. You appear to be afraid. We're making a statement, but we're giving them back areas of that they can understand so that they can communicate back with us. I know that sounds a little bit confusing, but we want to encourage them to communicate with us. So saying something like, if the patient says they're hearing voices, what do these voices appear to be saying? Has this ever happened to you before? Restating is another thing we can use, and that would be if a patient says, I can't sleep. Okay, well, they can't sleep. How would we get them to expand on that? We could say, are you having difficulty sleeping? I understand you're having difficulty sleeping. Can you tell me more about that? Another one that is called reflecting would be an example if a patient says to you, what should I do about my husband's affair? Well, that's an open question that you could go in many directions. Again, we don't want to give advice. We want them to make their own decisions. So the proper response would be, what do you think you should do about your husband's affair? So just keep those strategies in mind when you're speaking with a patient. That will really help. There are also things that we do not ever want to do. One of them is giving false reassurance. We never say to a patient in any situation, everything will be okay, because we don't know that everything's going to be okay. We really don't know that. And that is something that you can really get yourself in trouble with, especially with family members who are, making decisions on care. Can't say that things are going to be okay. We also don't want to give approval or agree. When they say to us they've made a decision, we don't want to say, I agree with your decision. It's not our place to say we agree or disagree with them. So again, we don't agree or disagree. We also don't want to advise, and that's anything that comes out sounding parental. I think you should. It would be better if you did. Those types of statements. When you are answering questions like this, keep in mind that we never want to sound parental. And what does that mean? That means that something that your parent would say to you that is judging or giving you advice that makes the hair stand up on the back of your neck is something we could never say to a patient. So keep that in mind and think about those situations when that has happened to you. This has happened to all of us. It could be a friend that is always giving advice. And the minute they open their mouth, you're like, are you kidding me? You're thinking to yourself, are you kidding me? Are you really going to give me advice again? We never do that with our patients ever. All right. We also want to try to stay giving open-ended questions. Something that ends with a question mark, not something closed. There are times that we do use closed-ended questions, and that usually comes in if we're asking, do you smoke? And they say yes or no. We then follow with an open-ended question, how many cigarettes do you smoke a day? So we can use a closed-ended if we know that we're going to be expanding that into an open-ended question. If it's something that a yes or no completes the whole series of questioning, that's okay if you're at that part of an interview or if you're at that part with your patient. In general, though, closed-ended questions are not good. Things that we should never do. We should never argue or challenge a patient, ever. It serves no purpose, and we should never praise a patient or give them false reassurance, like we talked about earlier. And what we need to do is we need to focus on facts and the client's perceptions. That's how we end up getting a good note. That's how we document. That's how we get to know our patients. We also are going to make observations. Not everything is a verbal conversation. We're going to make observations and document that. And then we are going to actively listen, meaning we're going to stay open. We're going to use silence and we're going to use clarifying words to make sure that we understand what they're saying. We don't ever want to question the client about sensitive areas unless we absolutely have to. And we don't ever want to try to sell a client on any type of treatment or procedure that we believe they should have. We want to give them the facts and they should make their own decision. These are the areas that you're going to be focusing on for your test, and I hope that this was a little bit helpful to point you in the right direction. See you next time. Thanks.